Okay, so good morning. So welcome for the free paper session 2. And before we start the session, we would like to announce few announcement about the sessions today. We have 8 oral presentation, and each presentation get 8 minutes for the presentation and 2 minutes for discussion. And I would like to inform the audience who join online. If you join as an attendee, please direct your questions Q&A box in your Zoom platform. And if you join as a panelist, please raise your hand, and then you will get chance to talk. We'll move to the first presentation. First presentation today. Topic is comparison of outcome of management in dengue hemorrhagic fever using minimal invasion and the standard management protocol in pediatric units of teaching hospital Karapitiya. Paper authored by Kaushalya PGC, Leonarach ND, Vijay Singh CG, Lankapriya RGS, Vimalasena TBGH. And paper is presented by Kaushalya PGC. Over to you.
Ladies and gentlemen, I'm Kaushalya Pusaguda, the Registrar in Pediatrics from Teaching Hospital Karapitiya. Thank you very much for giving us an opportunity to share our study, a comparison of outcomes of management of dengue hemorrhagic fever using minimal intervention and the standard management protocol in pediatric units of a Sri Lankan tertiary care facility. Dengue infection is a significant health concern. Most of the admissions are due to dengue fever or dengue hemorrhagic fever. Management of dengue hemorrhagic fever has changed over the past few years. At present, dengue hemorrhagic fever is managed following a standard protocol according to the national guidelines laid down by the Ministry of Health. According to the standard protocol recommended by the Ministry of Health, all the patients who enter into critical phase should be given intravenous fluids. Even the patients who can tolerate oral fluids should be given intravenous fluid at a minimum rate to keep vein open. Urine output should be measured hourly. To make it easy, urethral catheterization should be done. Regular hematocrit measurements is also supposed to be done 4 to 6 hourly. During the last epidemic of dengue, a deviation from standard protocol was observed in our wards due to various reasons. So, some patients were managed with minimal interventions. Those minimal interventions included total oral fluids instead of intravenous fluids, measurement of urine output 2 to 3 hourly without urethral catheterization, hematocrit measurement 12 hourly with full blood counts instead of 4 hourly hematocrit measurements. There aren't much research evidence in the literature to see the difference or the comparison between IV and oral fluids. In a study done in Taiwan had shown oral hydration may be as effective as intravenous fluids for adults with non-shock dengue hemorrhagic fever. There, they have concluded that patients treated with intravenous fluids were prone to develop pleural effusion and pulmonary edema. There are no similar studies conducted in pediatric patients. So, the objective of our study is to compare the outcomes of minimal intervention and the standard protocol during the critical phase in managing pediatric patients with dengue hemorrhagic fever admitted to Teaching Hospital Karapitiya. It was a comparative cross-sectional study conducted retrospectively using secondary data available in the clinical records of pediatric patients with dengue hemorrhagic fever. The critical phase was diagnosed by doing 2 ultrasound scans on those patients. So, we included pediatric dengue hemorrhagic fever patients admitted to Teaching Hospital Karapitiya during the year of 2019 who have undergone bedside or departmental ultrasound scan on a minimum of 2 occasions to objectively assess progressive leaking. Patients with incomplete clinical records and those who were managed with minimal interventions initially but later changed to standard protocol were excluded from our study. The study sample was categorized into 2 groups based on the type of management received. Minimal intervention group included patients who were managed with minimal interventions since the time of the diagnosis of critical phase. Patients who were managed according to the standard management guidelines issued by Ministry of Health since the diagnosis of critical phase were included in the standard protocol group. Relevant data were extracted from bedhead tickets and dengue monitoring charts using a data extraction sheet. Data analysis was done using SPSS statistical software. Moving on to the results, the study sample consists of 151 subjects. Out of those, 53 patients were managed with minimal interventions initially. 98 patients had been managed under the standard protocol. Out of those 53 patients, 28 patients had been changed over from the minimal intervention to standard protocol due to various reasons. Therefore, at the end, minimal intervention group consists of 25 patients and standard protocol group consists of 98 patients. Age, sex, duration of fever on admission, and hematological parameters including white cell count, hematocrit, and platelet counts on admissions were compared between two groups. There was no statistical significance between two groups. During the critical phase, again, some hematological and biochemical parameters were compared. So, there was no significant difference in the lowest platelet count during the critical phase in two groups. However, the highest AST, ALT, and hematocrit were different in those two groups, and those were statistically significant. When comparing the complications between these two groups, standard protocol group had more infections. 16 patients of standard protocol group had some kind of infection. None of the patients in minimal intervention group developed infection. Bilateral pleural effusion again present in 32 patients in standard protocol group, and only one patient was seen in minimal intervention group. Fluid overload with dyspnea was demonstrated in 25 patients in standard protocol group, but none of the patients in minimal intervention group developed fluid overload. Therefore, infections and fluid overload were common in standard protocol group, and it was statistically significant. The final outcome of those patients were compared. All the patients recovered with or without complications. There were no fatalities among our study group. About 5 patients in standard protocol group needed ICU care, but none of the patients in minimal intervention group needed ICU care. 61 patients had complications in standard protocol, and only one patient in minimal intervention group. That difference was also statistically significant. The fluid quota is the amount of fluid that patient is given during the critical phase. In standard protocol group, average of 91% of fluid quota had been given. In contrast, minimal intervention group needed average of 80% of fluid quota. That difference is also statistically significant. In two groups, there is no difference in the duration of hospital stay and final outcome. We would like to conclude that minimal interventions during the critical phase of the dengue hemorrhagic fever minimizes the risk of infection and fluid overload in children. So, we believe that using minimal interventions during the critical phase would reduce the workload of the healthcare staff, increase the patient satisfaction by reducing the pain and discomfort, and it will reduce healthcare costs. But further prospective studies are needed to make recommendations as there were limitations. Our study was a single center experience and it was limited by sample size. And it was a retrospective study, so clinical parameters which gives a clearer picture of patient were not analyzed in depth. Therefore, further large-scale prospective clinical trials are needed to determine the indications for minimal interventions. We would like to acknowledge the Director, Teaching Hospital Karapitiya, consultant pediatricians, and staff of the record room of Teaching Hospital Karapitiya for their immense support. Thank you.
Thank you, Kaushalya. Now time is to entertain with the questions. So there are no questions in the Q&A box now. So the panelists, you can ask questions. There are 2 panelists waiting for asking question. Dr. Ruwani, Professor Ruwani Hewawasam, please you to ask questions. Professor Ruwani.
Yes, thank you for your presentation, Dr. Kaushalya. Can you please tell me the age group of your participants?
Age group, pediatric age group, up to 14 years, madam.
So
Patients admitted to pediatric wards.
No, in both groups, were they in the same age group?
We couldn't, it was a retrospective study, we couldn't match the age, but after collecting the data, we have compared the age group. There was no significant difference, madam.
Okay, and then you mentioned that 28 out of these 53 moved to the standard protocol.
Yes, madam.
So what was the reason for that? You didn't mention about that in your presentation. That is like a majority, I think more than 25 that is left behind, right?
Yes. Initially, they were started to manage as minimal intervention group with oral fluids and without doing catheterization and without doing hematocrit measurements regularly. But after that, some patients, 22 patients, were started IV fluids mainly on night time. As there was retrospective study, we couldn't assess the clear indications for that. And others were catheterized due to urine output measurements problems and reduced urine output.
Yeah, the time is up. Thank you, Professor Hewawasam, asking for question. And finally, I thanks Kaushalya, PGC, for your important presentation. We have to move to the next presentation.
Thank you, sir. Thank you.
The next presentation will be trends in clinicopathological profile of thyroid cancers diagnosed over a period of 19 years at a single histopathology unit. The authors are Lienage TG, Muddua LKB, Muddua YDB, Abesiri Gunawardana DS, and Lienage AUG. Presenting author is Lienage TG. This is over to you.
Good morning. I'm going to present the trends in clinical pathological profile of thyroid cancers diagnosed over a period of 19 years at a single histopathology unit. Thyroid cancers show an increase in incidence over the past years. The latest cancer incidence data available for 2015 reveals thyroid cancer is the second most common cancer among females. It is the commonest cancer among females aged 15 to 34 years in Sri Lanka. The age-specific incidence rate of thyroid cancers has doubled from 7.4 to 15.9 per 100,000 population in females from 2010 to 2015. Galle is one of the 4 districts with highest crude incidence rate of thyroid cancers in 2015. There are 4 main types of thyroid cancers: papillary carcinoma, follicular carcinoma, medullary carcinoma, and anaplastic carcinoma. And papillary carcinoma, which is less than 1 centimeter in size, is known as a papillary microcarcinoma. The objective of our study was to describe the trends in clinical pathological profile of thyroid cancers reported at a histopathology unit in Galle. It is a descriptive cross-sectional study, and the study population was all thyroid specimens, that is thyroid lobectomies and total thyroidectomy specimens received at Department of Pathology, Faculty of Medicine, Galle from 2002 to 2020. Study sample was all patients who were diagnosed with thyroid cancers at the Department of Pathology, Faculty of Medicine, Galle. The study period was for 19 years. So all thyroid specimens reported at our unit from 2002 to 2015 was included in cohort 1, and which has been analyzed and presented in the GMA academic sessions in 2016. From 2016 to 2020, we continued collection of data, and it comprises the cohort 2, which was compared against data of cohort 1. Clinical pathological features, age, gender, clinical presentation, histological diagnosis were extracted from the laboratory worksheets and compared. And data analysis was done on SPSS. There were a total of 3,015 thyroid specimens. Cohort 1 had 1,735 and cohort 2 had 1,280 specimens. And there was a significant increase in thyroid carcinomas reported when compared with cohort 1. And there was a decrease in percentage of males affected. So this chart shows that in 2002 to 2015, that is a 14-year period, there were a total of 1,735 thyroid specimens, and out of which 266 thyroid cancers were there, which comprised 15.3%. And during the period of 5 years, from 2016 to 2020, there were 1,280 total number of thyroid specimens, and out of which 279 cancers were there. So which comprise about 21% of thyroid specimens had cancers, which was of significance. And when you compare the gender distribution, there was a reduction in males affected from this cohort to this cohort. When we compare the trends in age groups affected by thyroid cancers, there was no significant difference in age distribution between cohort 1 and cohort 2, but the 40 to 49 years age group, shown in gray color, shows an increase. The proportions of papillary carcinomas, that is papillary carcinoma more than 1 centimeter size, follicular carcinoma and other thyroid carcinomas, age and stage at presentation and association with autoimmune thyroiditis have not changed. But on the other hand, papillary microcarcinomas, that is a papillary carcinoma which is less than 1 centimeter in size, has increased significantly. When compared the total number of thyroid specimens, thyroid cancers, and the papillary microcarcinomas during the 14-year period, out of 1,735, we had 49 papillary microcarcinomas, that is about 2.82%. And when you compare the 5-year period, the most recent period, out of 1,280 specimens, 110 papillary microcarcinomas was diagnosed, which is about 8.59%, which is of significance. And the clinical presentation has changed with an increase in cancers presenting as solitary thyroid nodules and diffuse goiters, and the increase in severity of associated autoimmune thyroiditis. So this chart compares the trends in clinical presentation of thyroid carcinomas. Blue color bar shows multinodular goiters, orange color solitary thyroid nodules, and the diffuse goiters in gray color. And you could see that there's an increase in cancers presenting as solitary thyroid nodules as well as diffuse goiters. So our conclusions are, over 19 years from 2002, there is an upward trend in the number of thyroid specimens received for histopathology and the percentage of thyroid carcinomas diagnosed, as well as percentage of papillary microcarcinomas diagnosed. The clinical presentation of thyroid carcinomas also showed an upturn in presenting as solitary thyroid nodules and diffuse goiters. There is an increase in the severity of background autoimmune thyroiditis. Our references are Ackermann's Surgical Pathology and Cancer Incidence Data 2015. We'd like to acknowledge staff of Department of Pathology, Faculty of Medicine, Goa, and staff of Department of Surgery, Faculty of Medicine, Goa. Thank you.
Thank you, Dr. Tushari, for the interesting presentation. Now it's open for questions, discussion. And to start with that, I would like to ask a question. In your second cohort, it seems a higher rate of cancers. I want to know whether, because of the latter part of, with the development of many investigations like fine needle aspiration and ultrasound and other things, whether this second cohort cases are more highly suspected cases of cancers compared to first cohort. Can it be the reason? You have to unmute. Yes,
okay, now I am allowed to unmute. I didn't get your question. I was concentrating on because I cannot unmute this thing.
Yes, my question is, in second cohort, yes, sample, can it be some sort of screen sample with other investigation like fine needle aspirations and other radiological investigations and highly, suspected cases of cancers compared to the first cohort cases?
Yes, but especially now you saw that there was an increase in the solitary thyroid nodules. It may be because we got more ultrasound guided FNAs being performed, and because of that, so the cancer will present as a solitary thyroid nodule, especially when they are less than 1 centimeter, especially papillary microcarcinomas. I think the increase was mainly because of that.
Okay, thank you. We can entertain one more question. Okay, since we have only 30 seconds, we will move to the third presentation. Thank you very much for your presentations and your answering questions. So we will move to third presentation today. Topic is assessment of advanced ECG knowledge among postgraduate trainees in emergency and general medicine in Sri Lanka, authored by Gunawardana M.A. BA, Lanarol MI, Silva SN. And paper is presented by Gunawardana MABM. Yes, Gunawardana, over to you.
Good morning, everyone, and welcome to my presentation. My name is Dr. Bhaginda Gunawardana, acting consultant in emergency medicine. First of all, I must thank Gold Medical Association for giving this opportunity. The topic of my research is assessment of advanced ECG knowledge among postgraduate trainees in emergency and general medicine in Sri Lanka. I'll be discussing under these headings. We'll start with introduction. ECG is widely used in the diagnosis of many cardiac disorder and act as a preferred screening tool. An accuracy of interpretations is important for correct diagnosis to aid the decision-making process in patient management to avoid life-threatening conditions. Interpretation of ECG is basic medical skill. However, across the globe, many studies have concluded that undergraduate training on its own is not sufficient for accurate ECG interpretation. Studies have also shown that practitioners other than the cardiologist don't reliably recognize common abnormality in ECGs. In Sri Lanka, ETU, the first contact doctor could be a medical officer, emergency medicine or general medicine trainee, or trained emergency physician or general physician. Therefore, it is essential for medical doctors to have an adequate knowledge and ability to define, recognize, understand the basic pathophysiology of certain ECG abnormalities. Objective. The general objective of my study was to assess the knowledge of advanced ECG interpretation among postgraduate trainees in emergency and general medicine in Sri Lanka. Specific objectives were to assess the knowledge of Sri Lankan emergency and general medicine trainees in diagnosis ECG based on common and critical emergency condition, and to assess the years of work experience and years of training of Sri Lankan emergency and general medicine trainees in diagnosis ECG. We'll move to methodology. My study was descriptive cross-sectional study, and study setting was Postgraduate Institute of Medicine, University of Colombo. Study population was specialist trainees for emergency medicine and general medicine registered under the Postgraduate Institute of Medicine, University of Colombo. Sample size was 200. It was taken after reviewing previous similar studies and expert advice from statistician. Sampling method was convenience sampling used to collect data. Participants were contacted via email through a contact list obtained with the permission of Postgraduate Institute of Medicine. Inclusion criteria was trainee who are currently registered in both emergency medicine and general medicine training program at the time of research. Trainee who were currently participating outside Sri Lanka and had some sort of foreign clinical training for more than 6 months, and who had cardiology ward exposure before more than 6 months were excluded. Data was collected using self-administered online questionnaire, which assessed the clinical scenario-based ECG knowledge of trainee via set of multiple choice question. All ECGs in questionnaire were selected by subject expert, and they were clinically significant. These were independently reviewed by 2 cardiologists, and there were no disagreements. Data was collected period between 15th of May to 25th of May 2021. All the data collected was entered to the computer database, and they were analyzed through using Microsoft Office Excel 2010 and IBM SPSS version 20 software. Ethical approval was taken from Ethics Review Committee of National Hospital of Sri Lanka. Informed written consent was taken before participation. Introductory note was provided to all participants with online questionnaire in English. Confidentiality was maintained by not documenting names and any other personal identifiable details. And there were no harm to any person involved in this study, and all steps of the research were done after ethical consideration. When we come to the results, with 188 valid responses, majority were from emergency medicine trainees. This chart shows the distribution of participants by their years of postgraduate training. Most of the participants had less than 1 year of PG training, and only 4.5% had PG experience of more than 5 years. And this chart shows distribution of participants according to their overall work experience. Majority were within a category of 6 to 10 years of total work of experience. This table shows results of ECG condition arranged in the that has arranged in the most correctly diagnosed. Most correctly diagnosed condition, ECG condition, was Brugada syndrome. 181 of participants were able to correctly diagnose Brugada syndrome, and followed by hyperkalemia and long QT syndrome. Least correctly diagnosed condition was pericarditis. Only 36 of participants were being able to diagnose it correctly. Depending on the type of the question, all the 10 questions we asked in our questionnaire were categorized into 4 main domains. This was done due to identify further training. For example, question regarding trifascicular block, which was the question number 5, were included in the criteria for diagnosis and clinical correlation. So their performance in relation to this all 4 categories is as follows. On the left-hand side chart shows self-reported confidence in interpreting ECG of participants. 58% of participants say they are confident in interpreting ECG, and 19% say they are not confident. On right-hand side chart shows self-reported need for further training. 83% of participants say they need further ECG training. To compare the PG experience in years with mean accuracy of diagnosis ECG of maximum was 1. Number of years were categorized into 3 as less than 3 years, 3 to 5 years, and more than 5 years, except 2 questions that is related to pericarditis and WPW. The participant with more than 5 years of experience scored more than other 2 categories. However, in another 3 questions, the participant with less than 3 years of PG experience scored more than one with 3 to 5 years of PG training, suggesting that there were no clear relationship between years of PG training versus accuracy of ECG diagnosis and the interpretation. Further, there were less participants in latter 2 groups. Analysis to compare the work experience in years with with mean accuracy of diagnosis ECG yield similar results. Participants were grouped into 3 categories, and less than 5 years of work experience, 5 to 10 years of work experience, and more than 10 years of work experience. Except 2 questions relating to pericarditis and Brugada, all other questions show that there were no clear improvement in ECG diagnosis with the year of experience. The conclusion of my study: most correctly identified diagnosis was Brugada, and least correctly identified was pericarditis. The next correctly diagnosed were hyperkalemia and long QT syndrome. All the ECG were related to scenario that a qualified doctor who work in emergency department should know. Most postgraduate trainees were unable to diagnose and correctly interpret the selected ECGs appropriately, which implies that there is low a level of accuracy for some critical ECG diagnosis. An accurate diagnosis and interpretation is vital for patient management. Therefore, adequate training needs to be implemented for those who are involved. These are my reference, and thank you very much for your attention.
Thank you, Dr. Gunawardena. As time is elapsed, so I would like to invite the attendees or panelists to ask one question. As there's no question, so I would like to ask one question. In your sample, I saw it has been demonstrated that there is a below average, the diagnosis is made correctly in left bundle branch block. What is the reason for that?
Maybe because we gave a case scenario, and with that we provided some ECG. Maybe they won't have not been able to identify. Maybe they are not be able to identify this ECG according to case scenario. That may be the reason.
Thank you, Dr. Gunawardena and the rest of the authors for your important presentation. I would like to move to the next presentation. The topic is effect of alendronate and vitamin D3 treatment on bone turnover markers in postmenopausal women with high bone fracture risk. A double-blind randomized control trial. The authors are Ratnayaka H, Lekavasam S, Vikramatilaka CM, Lenora J. The presenting author is Ratnayaka H. This is over to you.
I am Hasanga Ratnayaka from University of Ruhuna. Title of my presentation is Effect of alendronate and vitamin D3 treatment on bone turnover markers in postmenopausal women with high fracture risk, a double-blind randomized control trial. Moving on to the introduction, bone turnover markers are proteins or derivatives of proteins that are released during bone remodeling. They could be collagen breakdown products, matrix proteins, or enzymes. Bone markers are increased in osteoporosis, and these are expected to decrease significantly after receiving anti-resorptive treatment in osteoporosis, and they can be used to monitor the efficacy of the treatment. Further, bone markers provide early therapeutic response compared to BMD values. Our objective was to evaluate the degree of response of bone markers following alendronate and vitamin D3 treatment in postmenopausal women with high fracture risk. This was a double-blind randomized controlled trial conducted during 2018 to 20. The sample was collected randomly from Bopipodal MOH area goal. Postmenopausal women aged more than 50 years were considered, and they had high fracture risk. Total of 60 individuals were considered for the study, where treatment group had 30 individuals and control group had 30 individuals. Ethical approval for the study was received from Ethics Review Committee, Faculty of Medicine, University of Ruhuna. We excluded participants with diseases which could affect bone metabolism, and also we excluded participants who were on medications that could affect bone metabolism. Eligible participants were allocated into treatment group and control group using block randomization. Then, baseline bone marker levels were measured. Treatment group received 70 milligrams of weekly alendronate with daily vitamin D3 dose of 1000 international units. Control group received a placebo similar to alendronate tablet with daily vitamin D dose of 1000 international units. Then both groups were followed up for 6 months. And after that, again, bone marker levels were estimated. These final bone marker levels after 6 months were compared with the baseline values to see the significant difference. Bone mineral density of hip, femoral neck, and spine were measured using DEXA at Teaching Hospital Karapitiya. High fracture risk was determined according to the FRAX model, which was validated for Sri Lanka based on femoral neck, BMD, and clinical risk factors recommended in the FRAX webpage. Women with major fracture risk more than 9% and or hip fracture risk more than 3% was considered to have a high fracture risk. We considered two types of bone turnover markers, bone resorption marker CTX and bone formation marker P1NP. Normally distributed data were presented as means and standard deviation. However, bone marker levels were not normally distributed, and log transformation was done prior to the analysis. Therefore, bone marker levels were presented as geometric mean with 95 confidence intervals. Bone marker values before and after the treatment were compared by paired t-test. P-values less than 0.05 was considered as statistically significant. Any of the considered parameters such as age, menopause years, BMI, BMD parameters, fracture risk data, and bone marker data were not significantly different between treatment group and control group at baseline. According to results, in treatment group, mean CTX levels reduced by 60% after 6 months when compared to the baseline. Mean P1NP levels were reduced by 39% after 6 months of treatment. And these changes were significant. In control group, significant mean differences were not observed for bone markers, CTX and P1NP, between baseline and after 6 months. The findings reported in the present study are congruent with the available literature. Literature shows 30 to 70% reduction of CTX and P1NP upon treating with oral alendronate after 3 to 6 months. Considering this information, certain countries such as Australia, China, Japan, and Thailand have already been utilizing these markers in the management of osteoporosis. In conclusion, combination of alendronate and vitamin D3 treatment significantly reduced bone turnover markers. Vitamin D3 alone had no significant effect on serum bone marker levels in this group of women. CTX and P1NP would be promising markers in monitoring early therapeutic response of postmenopausal women with osteoporosis and high fracture risk in Sri Lanka. However, more studies with larger sample size are recommended to verify the findings generated from the present study. These are the references. And I would like to acknowledge technical staff of Nuclear Medicine Unit, Faculty of Medicine, University of Ruhuna, for performing ELISA assays, and would like to acknowledge technical staff of DEXA unit for performing DEXA scans for the participants. And also I would like to thank participants of this study for their kind cooperation, and would like to acknowledge UGC block grant for the financial assistance. Thank you.
Thank you, Ratnayaka, for interesting presentation. Now is paper open for discussion, questions, comments. You can make your questions in Q&A box. So to start with, I would like to ask one question. This is a very interesting study. Are there any new findings compared to other studies in other countries and other society with other nutritional status? Is there new findings in this study?
The question is not clear to me, sir.
No, my question is, compared to studies in other countries with other nutritional status, is there something new in your study? Result, I mean, in your result.
Yes, sir, that means the bone markers have been studied in many countries. That's because the behavior of these bone markers are different from one country to another. That is based on their environmental factors, genetics, and many other things. The new thing that I did was conducting this research in Sri Lanka, because these bone markers have not been studied for Sri Lankan population. So other developed countries, they have already studied and they are being utilizing these markers for their management of osteoporosis, but we are still not doing that. So before doing that, we have to see the behavior of these bone markers in our population. So that is the new thing that I have found in my study. And also in most of the literature data, they haven't considered specifically high fracture women. They had larger sample size, but they have just considered women with osteoporosis. But the real group of which need the treatment is the women with high fracture risk. So that is a new finding of my study.
Okay, thank you very much. Of course, we can see one question from the audience, but due to the time factor, we will move to next presentation.
Thank you, sir.
The fifth presentation is on, the title is Zero Prevalence of COVID-19 Among High-Risk Population in Galle, Sri Lanka, a story behind successful control of first wave of COVID-19 pandemic. Authored by Palangasinghe DR, Disoisa PDWD, Dahanayaka NJ, Herath HMM, Disilla PU, and paper is presented by Palangasinghe DR. Over to you, Palangasinghe.
Good Today our presentation is about zero prevalence of COVID-19 among high-risk population in Galle, Sri Lanka. A story behind the successful control of the first wave of the COVID-19 pandemic. As you all know, COVID-19 is the most devastating global health emergency faced by us in the current context, and its impact on the healthcare systems have been immense. And not only healthcare systems, also all facets of society, including education, socio-cultural interactions, economy, had been massively impacted by this pandemic. It's a well-known truth. Looking at the control strategies adapted by different countries to limit the spread of the disease, there were two types. Mainly, some of the countries like China, Sri Lanka has adopted a very strict control measures to combat the pandemic. That included and not restricted to lockdowns, closure of schools, airports, mandatory quarantine and screening of all first-line contacts, and so on. And some of the countries has adopted the less stringent control strategy. So it was well known and it was quite evident looking in retrospect. All the countries has adopted strict control measures, had been successful in reducing the number of cases and was able to limit the transmission of the disease. And to what extent these strict control measures are successful has to be scientifically determined by zero prevalence studies. So in a given community, prevalence of COVID-19 can be determined by viral detection tests as well as antibody detection tests. So these antibody detection tests can be adapted in communities which are non-vaccinated. So we have conducted this survey from June 2020 to August 2020 by performing antibodies against SARS-CoV-2 and PCR testing in a high-risk population in Galle. And there we have selected 100 tourism industry workers who has had close contact with foreign tourists visited Sri Lanka during the period of 3 months starting from 1st of January 2020. And as you all remember, from June to August 2020 was the time where we came to an end of the first wave, and we wanted to determine how successful we really were in controlling this pandemic by adapting those strict control measures mentioned. So only scientific way of determining the success of these control measures were in performing these zero prevalence studies. So out of those 100 participants, all 100 participants we have done antibodies, IgM and IgG antibodies against SARS-CoV-2 by conducting it in a new coronavirus IgM rapid test kits, which had a sensitivity of 98.8% and a specificity of 97.7%. And PCR testing was performed in 81 participants, obviously because 81 participants only consented for PCR testing, and both these tests were performed on the same day. And what have we found? All 100 participants were tested negative for antibodies, IgM and IgG antibodies against SARS-CoV-2, and all 81 individuals who consented for PCR was tested negative. So what does it indicate? It proves zero prevalence in this high-risk community in Galle from June to August 2020. And that indicates the success of these control measures adopted as a country. So let's see about the socio-demographic factors of the study participants. In terms of age, gender, and occupation, you can see the breakdown in this table. So majority were males, 89% of were males, obviously because of the industry we have selected. And majority of the participants were in the age range 30 to 49. They are in the economically productive age group. And all these participants being tested negative is a fantastic achievement in terms of healthcare indices, isn't it? And this graph, you can see the distribution of comorbidities. About 32% of participants had some comorbidity, at least diabetes, hypertension, heart disease, bronchial asthma, chronic lung disease, dyslipidemia, and other comorbidities were found in 32% of the study participants. So this is a fairly distributive or a representative sample from the community. And as we all know, these strict control measures had been successful in achieving a zero prevalence in this high-risk population in goal. And in conclusion, we can say the negativity of both PCR and antibody test among this study population provided us strong evidence for the healthcare success of the control measures adopted during the first wave of pandemic in Sri Lanka. And one of the important questions that arises with that, why didn't we sustain these measures during the following waves, second, third, and fourth phase, and why we are at a situation now where we have almost exceeded the healthcare capacity with devastatingly high number of ICU admissions and deaths that we never expected by moving to a less stringent strategy from a tight control strategy in COVID-19 pandemic. So there are lots of debates and arguments about lessening these control strategies, loosening these control strategies. But the most important question we have to leave here is how sustainable these measures in terms of economy, education, and socio-cultural interactions as a lower middle income country like us. Not only as a lower middle income country, even countries who had a high income with very well developed healthcare facilities and a very wealthy economic strategies, they also could not sustain these control measures. So that is the most important question we have to answer, which is open for the debate. So these were our references. And I would like to thank study participants, laboratory staff, and Dr. Gaya, consultant microbiologist, in advice to conduct this survey. So with that, I would like to open the stage for the questions from audience.
Thank you, Dr. Palangasinghe. Now the forum is open for questions. So there are no questions from Q&A box. So the panelists, so you can ask questions if they're interested questions with you.
One question from Q&A box. One question from Q&A.
Yeah, one. So one question now from Q&A box. The question is, having seen how the pandemics unfolded subsequently, do you still believe this is a cost-effective strategy? Dr. Palangasinghe?
Yes, thank you for the question. So it's looking in retrospect, it's not a difficult question to answer, but only problem is prospectively how practical to adopt these measures, and as I mentioned, how practical to sustain these measures. But we have to perform surveillance in terms of economy and the healthcare statistics and give an analysis for that. But personally, I do believe if we had sustained these control measures, it would have been
health as well as economically productive, looking at the number of deaths, ICU admissions, and the immense cost that we are spending on each patient who get admitted to an ICU or who requires oxygen. So ultimately, it looks that it would have been economically productive also, not only in terms of health statistics. So that's my personal opinion. But as I mentioned, it is still debatable, and maybe lots of pros and cons related to that. But if you ask for my personal opinion, as a physician looking after patients with severe COVID pneumonias, yes, I believe even as a low middle income country, we would have been more successful in terms of economy and health if we have sustained these measures.
Thank you, Dr. Palangasinghe, and the rest of the authors for presenting the timely important study. So I would like to move to the final presentation of this session. This presentation will be on clinical profile of the patient with cerebrovascular accident admitted to the emergency treatment unit at Teaching Hospital, Karapitiya. Presenting author is Karunanayaka A. The rest of the authors are Veerasuriya MA, Munavira NW, Ranasinghe RDNN, Dahanayaka RLS, Airangani SAM. This is over to Dr. Karunanayaka A.
The title of my presentation is Clinical Profile of the Patients with Cerebrovascular Accident admitted to the Emergency Treatment Unit at Teaching Hospital, Karapitiya. The authors are M.A. Veerasuriya, N.W. Munavira, R.D.N. Ranasinghe, R.L.S. Dahanayaka, S.A.N. Irangi, and A. Karunanayaka. CVA, or cerebrovascular accident, is the fourth commonest cause for in-hospital mortality in Sri Lanka. The community prevalence of CVA in Sri Lanka is 1.6%. Spontaneous non-traumatic intracranial hemorrhage, SICH, is defined as intracranial bleeding that occurs without trauma or surgery. SICH accounts for 10 to 15% of all CVA and is associated with a higher mortality rate than ischemic type. Data on SICH in Sri Lanka are not available, mainly due to the unavailability of brain imaging facilities in government hospitals. The objective of the study was to determine the clinical profile of the adult patients with first ever cerebrovascular accident admitted to the emergency treatment unit at Teaching Hospital, Karapitiya. Method: consecutive consented adult patients with first ever cerebrovascular accident referred to ETU-THK in first 3 months of the 2020 were recruited for this prospective observational study. Ethical approval was obtained from the Ethics Review Committee of Faculty of Medicine, University of Rohuna. Results. This study includes 58 patients presented during first 3 months of the 2020. 60.3% of them were female patients, 39.7% of them were male patients. Mean age of the male patients was 66.1 years and female patient mean age was 64.6 years. The mean age between two gender were not statistically not significant. The cohort includes patients from 31 years to 94 years of age. In both sexes, majority of patients were from 70 to 79 age group. Majority of them had a previous medical history. Hypertension and diabetes mellitus were the commonest non-communicable chronic disease among the patients, followed by dyslipidemia and bronchial asthma. 17% of them had 3 or more chronic disease at the presentation. During hospital stay, 17% of them were diagnosed with hypertension, and one patient was diagnosed with diabetes mellitus, and one patient was diagnosed with brain vascular malformation. When we analyze the adverse events occurred within 24 hours before the incident, 10.3% of them had sleep deprivation, and 6.9% of them had stressful physical or psychological event or ethanol consumption within 24 hours before the incident. Patient denied usage of recreational drug or sexual enhancement drugs during the particular period. 51.7% of them had a family history of cerebrovascular accident. 20% of them had given a history of cerebrovascular accident among the mother of the patient. Limb weakness and headaches were the most common initial symptoms of the patient, followed by slurred speech, nausea, and vomiting. 51.7% of them had spontaneous non-traumatic intracranial hemorrhages. Mortality rate was 33.3% among the SICH patients, which is compared to ischemic type CVA, it was around 2.3%. SICH was slightly higher among the female patients. However, that finding was not statistically significant. Glasgow Coma score, systolic blood pressure, diastolic blood pressure, pulse rate, respiratory rate, and oxygen saturation were analyzed as the initial clinical parameters. However, initial parameters were statistically not different between the sexes of the patient. Also, initial clinical parameters were not statistically significant between according to the CVA type. NIH stroke scale score was used to determine the severity of the disability. Analysis has shown that on admission, NIH stroke scale score was statistically significantly higher among the female patients. However, NIH stroke scale score was not significantly different according to the type of CVA. Conclusions. Patient admitted with CVA to ETU at THK have shown high prevalence of spontaneous intracranial hemorrhage, and the mortality rate was significantly higher among the SIACH compared to the ischemic type. And CVA patients were suffering from non-communicable chronic diseases, and the prevalence of non-communicable chronic disease is also high. Female patients had more severe disability in the initial presentation than the male patient. Those are my references. Thank you.
Thank you, Dr. Karnanayaka, for your interesting presentation. Paper is open for discussion. Now you can ask questions, put your questions in. Yes, there is one question from the chat box. Question is, any reason for higher percentage of ICH than other series? ICH is about 20 to 30% in other series. Is it due to reference of more ICH to the teaching hospital Karapiti due to availability of NSU facility?
Thank you for your question. I also believe that as a tertiary care center with NSU facilities and imaging technique, and the ETU is a specialized unit to care the acute patients with acute presentation. So that is the one that may be the one reason which has contributed for higher ICH among the severe patients presented with the ETU. However, this study was initiated by the researchers having observed that there is a significantly high percentage of ICH among the severe patients, and then the researcher has some doubt whether there is linked to use of this recreational drugs or sexual enhancement drugs. So that is the one observation which has led for this to start this research. But generally, we have some impression that ICH levels, the percentage of ICH is somewhat higher than the reported cases. So that is the one initial research question we had before embarking on this research.
Okay, thank you very much for your interesting presentation. And with that, we conclude second pre-paper sessions of 80th annual academic sessions of Gold Medical Association. And I would like to thank all the presenters and authors and the participants all over who attend online. Thank you very much.
Thank you.